Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, A Randomized Trial of Cognitive Behavioral Therapy for Insomnia, CBTI, and armodafinil for insomnia following cancer treatment, by Joseph Roscoe et al. My name is Gary Roden. I am head of the Department of Psychosocial Oncology and Palliative Care at Princess Margaret Cancer Centre in Toronto, Canada, and a professor of psychiatry at the University of Toronto. My oncologic specialty is supportive care. Insomnia is a common problem, with symptoms reported by up to 70% of patients in primary care and up to 30% of individuals in the general population. This self-reported symptom is characterized by difficulty initiating or maintaining sleep, or by sleep that is chronically non-restorative or poor in quality. Insomnia is by definition associated with daytime impairment, and such symptoms as irritability, fatigue, mood swings, and concern about loss of sleep. Insomnia symptoms are particularly common in cancer patients due to the effects of the disease, its treatment, or to the impact of comorbid symptoms such as pain, depression, or anxiety. Recent research suggests that insomnia in cancer patients may be part of a treatment-related symptom cluster, also referred to as sickness behavior, that is caused by the effects of pro-inflammatory cytokines activated by the disease or by its treatment. Clarification of this mechanism has the potential to lead to targeted biological interventions to control symptoms. Pharmacologic agents are currently the most common interventions used to treat insomnia, although their prolonged use may be associated with poor quality of life and more symptoms. Such use is not recommended, although this practice is common, particularly with older individuals with insomnia. The tendency of healthcare providers to treat insomnia with medication may be due to a variety of factors, including the efficacy of the medication and the ease of its administration, the pervasive marketing of such medications, and the lack of training or available resources to deliver other treatment modalities. Cognitive behavioral therapy is a non-pharmacologic approach that has been shown to be effective in the treatment of insomnia, with effects that may be more enduring than those of medication. CBTI refers to the modification of cognitive behavior therapy, or CBT, for the treatment of insomnia. This is a multi-component intervention that includes identifying and correcting sleep-interfering activities, regularizing the sleep-wake cycle, and diminishing or modifying stressful thoughts that adversely affect sleep. A large body of evidence has shown CBTI to be an effective treatment for insomnia. A recent systematic review demonstrated that CBTI with cancer patients with insomnia results in improvement in subjective sleep outcomes, as well as in mood, fatigue, and quality of life. However, Roscoe et al. Were concerned about the relatively low compliance rate with the instructions for CBTI that has been found in research with this intervention. They question whether such non-adherence may be due to the unwanted effects of daytime sleepiness and impaired function due to the daytime sleep restriction that is required in the CBTI intervention. They have proposed that a wakefulness-promoting agent, such as armodafinil, might improve compliance and therefore result in better outcomes with CBTI. Roscoe et al. Report here the results of a double-blind, 4-arm RCT that was undertaken to determine whether armodafinil could improve outcomes from CBTI in cancer patients with insomnia. They randomized 96 cancer patients with insomnia to CBTI and placebo, CBTI plus armodafinil, armodafinil alone, and placebo alone to treat insomnia in cancer survivors. The participants were cancer survivors in 2 northeastern cities in the United States who had insomnia that began or became worse with the onset of cancer or cancer treatment. The primary outcome of this trial was insomnia severity, measured by the Insomnia Severity Index, and the secondary outcome was sleep quality, assessed by the Pittsburgh Sleep Quality Index. The CBTI was delivered over 7 weekly sessions, 4 of which were delivered in person and 3 over the telephone. The investigators in this study found that both groups that received CBTI showed benefit on both the primary and secondary outcomes compared to the placebo group, and that these effects were enduring at the 3-month post-intervention follow-up. However, the addition of armodafinil to CBTI was not associated with a better outcome than CBT alone. Not surprisingly, the CBTI was no different than the CBTI plus placebo, and armodafinil alone did not differ from placebo. These findings did not confirm the investigators' hypothesis about the benefit of armodafinil on sleep outcomes nor on treatment compliance, which is above 90% for all study arms. The researchers speculate that the relatively low and fixed dose of armodafinil 50 milligrams BID may have contributed to the negative findings regarding its inclusion in the treatment. The Roscoe et al. Study is further confirmation of the value of CBTI for the treatment of insomnia, although the investigators have not elaborated on steps that could be taken in order for this intervention to be included in routine care. This may include education of health providers about its benefit and a systematic approach to the training of health professionals in the principles of CBTI and/or available resources for its provision. Some aspects of CBTI could be included in the education of patients when they initially present for treatment and during the subsequent course of the disease and survivorship. Finally, it is important for clinicians to consider other factors, such as depression, anxiety, pain, and other symptoms that may contribute to disturbances in sleep and they may benefit from specific interventions. The timely treatment of insomnia in patients with cancer may be of great benefit in preserving the quality of life and subjective well-being of such individuals. CBTI, or at least elements of this intervention that could be routinely applied in the clinic, are a valuable tool to assist in this task. Pharmacologic approaches may also be of value in the treatment of insomnia in cancer patients in the short term, although these medications may have undesirable effects when used on a long-term basis. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.